pulmonologists, physiologists, their interventions. We have also interventional radiologists. So this is our case. Our center is pretty new center, so starting since last 5 years. So the first 3 years is the number of cases not much, but last 2 years the cases rapidly increasing. So approximately 100 aneurysms come per year in our centers, and the first 2021 is even more. So until February, so I think we have almost 30 cases of aneurysm clipping. This is some of our cases. This is the sample of microsurgical clipping cases. This is the first case. This is the giant thrombus become aneurysms. Patient is unruptured. Patient come with headache. You can see this is narrow neck become aneurysm, actually posterior pointing. So we can see this is halo sign circle the dome of aneurysms, compress the mesencephalon, the right mesencephalon, at the left mesencephalon. So we do aneurysm clipping, right paternal approach. This is Sylvian opening. So this is ICA. This is the ophthalmic artery. We try to trap the aneurysm. This is the dome. This is the M1. This is the M1. We try to trap the aneurysms and looking for the outlet of the become aneurysms. So we use the angle penetrated clip. We opened the temporary clip, and still there's a aneurysm filling, and there's a rupture nearby the neck of the aneurysms. So I put a cotton and put another angle penetrated clip. Like so, the filling is quite good, and we continue to take out the thrombus. So the thrombectomy just partially until the compression for surrounding structures reduce and patient symptoms is recovered. This is the post surgical angiography. There is no dome filling. This is our second case. This is aneurysms with a giant aneurysm with a common aneurysm with optic nerve compression. Okay, we can see this is the aneurysm. Compress the optic nerve. Patient come with the hemianopsia. So this is the aneurysm dome. You can see the optic nerve compressed by the aneurysm dome. This is contralateral M1. This is lateral M1.
Dr. Abrar, can you
Yes.
larger your movie, your presentation?
Sorry.
Larger your view.
Okay. Okay. Okay.
Okay, this is a presentation view. Okay.
Okay. This presentation. Okay. Okay. So after temporary clip, and we clip the neck of the aneurysm. This is the ICG. And you can see there's a complete obliteration. This is post-operative angiography. You can see this complete obliteration of the acorn. This is third case is the MCA with the large intraparenchymal bleeding. So very red, angry brain. So we try to open the white Sylvan fissures. This is the A1 temporary clip, and because of the big MC aneurysms, so I'd like to coagulate the dome to shrink the dome so I can see the neck clearer. So because the positions of the aneurysm is a bit wide neck, so I try to put multiple stack straight clip to reconstruct the neck of the aneurysm. This is the first clip, this is the second clip. Or because of more than 90% of patients come with our center, I think in Indonesia also, most of the patient aneurysms come ruptured cases. It's different with Japan. Most of the patients come with unruptured. So even though the clipping surgery is success, frequently the patients still struggling in the ICU because we should face the vasospasm and infection and hydrocephalus. So I think it's still our problem. So the team should be very, very competent to treat post-operatively the rupture cases. So this is a basilar tip aneurysm. So this is a white neck, small aneurysm, but the neck wide enough so it cannot coil the patients. So this is a modified OZ, right modified OZ approach on wide Sylvan dissection. For basilar tip aneurysms, we should open Sylvan fissure very wide and retract the temporal lobe. This is the aneurysm dome. You can see this. We should see very clear the perforator around the tip of the basilar. Okay, this is postoperative imagings, complete tip. The patients recovered well, and 2 weeks after that, patient got infected by COVID-19. And patient come back to isolated ward in our center. This is another failed clipping aneurysms. The patients come with a rupture case, but we can see these aneurysms is, sorry. These aneurysms are pointed medially. So we approach the neck from the medial side.
Ditunggu kehadirannya di lantai 7 zona A. Terima kasih.
We approach from optical carotid systems. but we cannot see because we want to preserve the PCOM. So you can see this is the optic nerve, this is the ICA. We try to clip from the optical carotid systems. We see the dome, we see the PCOM, we try to clip, and we think that the clip already good, but we already check also with the ICG. The next day, we do the angiography, and we still saw very big aneurysm there. So we continue patient with the coiling. Luckily, because the clip make the neck of the aneurysm become narrower, so the coiling become much easier. So this is also the case too, the vertebral artery trapping. You can see these vertebral artery aneurysms, fusiform aneurysms, and we trap the vertebral artery aneurysm because the aneurysm's positions is below the pica aneurysms. This is the, can you see my pointer? Okay. This is another case of a giant IC aneurysms. Patient come with a sudden ptosis. There is no hemorrhage. We put a pipeline in these patients. So patient can recover after 3 months and aneurysm is gone. So the take-home message for my presentation is multidisciplinary approach is very important. Patient is the most important person, not us. Discuss every cases and treatment choice with your team and master both skills if possible, especially in Indonesia because we still need a aneurysm clipper because the endovascular treatments still very expensive because we see that most of young neurosurgeons, they tend to learn endovascular treatment, but still never forget about the aneurysm surgery. Or if there's no, but if possible, make a team up with an interventionalist. The rule of thumb is, if amenable for both treatment, endovascular treatment and surgical treatments, in our center, coil is the first choice. For young and good grade, so clipping surgery is preferable because of durability. For old and poor grade, endovascular treatment is preferable. Endovascular treatment may be considered for incomplete clipping case, but we should always aim to get the complete occlusion on the first try. For difficult anatomy and thrombus giant, clipping is preferable. Compression or mass effect caused by aneurysm or hemorrhage, clip is still preferable for decompressed aneurysm. Thank you. I think that's my presentation, Dr. Asra.
Okay.
Thank you very much.
Thank you, Dr. Abrar. Good presentation showing your experience in Jakarta doing this aneurysm treatment, both open surgery and endovascular. And now we move to the last speaker, Dr. Nur Setiawan Setiaroto. He is my colleague in my department. He is a dual neurosurgeon doing both endovascular and clipping surgery, but mostly he's my endovascular guy. So we manage together our patient. And he will talk about how to perform treatment of aneurysm with endovascular modality. Please, Dr. Nur Setiawan, you can showing us your experience in Surabaya. Please, your time is 20 minutes.
Thank you, Dr. Asra. Good morning, college. So
Morning.
is my presentation can be seen clearly?
Yeah, please use the presentation. Okay, thank you.
Okay. So I would like to present my experience in EVP treatment for the aneurysm in my hospital in Surabaya. So basically, I do most for the endovascular case, and Dr. Asra do most in the open surgery cases. So we always share our our expertise for the best treatment for the patient. So here I would like to present. So this is for the introduction that we know that aneurysm from the morphology and the clinical finding, and we know that the aneurysm can be found in the ruptured case or in the unruptured. And unfortunately, like Dr. Abra said in the previous presentation, that in Indonesia and also in Surabaya, in my town, that most of the cases came to the hospital with a stroke case or the subarachnoid hemorrhage. So then we know that from the size, we have a small or even the giant aneurysm. And then from the pathology, we know that it will be true aneurysm or pseudoaneurysm. And we start the endovascular service from the 2014. And this is the 2016. We have treated 57 cases. And as we may see that most of the cases were the ruptured cases. And then 50% goes to went to coiling, and the 44% went to clipping. And here the data, the 2016, that most of the posterior circulation aneurysm went to the endovascular treatment. Here the small history that we know that early 90s that the GDC coil was the first coil in the market, and this is nowadays available for the many brand for the coils. And we see that in the 90s, in the early of 90s, it's quite a good introduction for the coils for the treatment of the aneurysm. This is the paper from Dr. Higashida from the UCSF that we know that in the 1997, he used the coronary peripheral stent for treat this kind of the aneurysm. This is the wide neck Vertebral Basilar aneurysm, and then he used the coronary stent he put the stent here, and then he put the coil, the DC coils to treat the aneurysm. And then nowadays we know that we have many intracranial stents for treating aneurysm, even for the flow diversion. So this is the endovascular perspective from the morphometry of the aneurysm. We know that previously the patients that are ideal candidates for the coils only are those with the aneurysm with a narrow neck less than 4 millimeter, or even for the low to doom neck ratio. But now with the adjunctive techniques such like balloon inflation, stent placement, and multiple microcatheter, we can treat such a challenging aneurysm, but still we have some difficult to treat for the aneurysm in the specific cases. So in my hospital, we use some several techniques and assisted devices for the EVT. It's like the microcatheter shaping or looping, and then we use the multiple microcatheter or the balloon remodeling or even the stent assisted. And the latest we use also already the flow diversion for treat the giant aneurysm in the arterial circulation. And then the technical challenging in coil embolization of the brain aneurysm, we know that there will be some chance of impingement of the coil loops into the burn artery, or even the aneurysm sac if we cannot make the coils in a good pack density. And then there's still some continuing communication with the Barron vessel due to the loss of the coil packing. So this is some of the basic approach that we use to shaping of the microcatheter, of the looping of the microcatheter, we know that like this kind of the aneurysm, the para-ophthalmic, the angle and the projection of the aneurysms, it will also make some difficulties. So based on the parent artery curvature or even the angle, and then we can shape the microcatheter for the preference. Like this aneurysm, we use the preset 45 degrees of microcatheter, and then so we can see that we can get a good positioning of the microcatheter inside the aneurysm, and then we can treat the aneurysm with a good packing density, and also we can also see that this neck of the aneurysm occluded in a good position. And this is some paper about how important the shaping and navigating methods for the arachnoid aneurysm. This kind of shape, specific dedicated in the upper picture, we can see that this is the pigtail and then pigtail shaping, and then this is dedicated for the arachnoid aneurysm located in the superior, in the inferior projection direction of the tube of the aneurysm. And the inferior picture, we can see in the picture below, is it the microcatheter shape dedicated for the superior projection of the dome. So by make a good proper shape of the microcatheter, we can treat the aneurysm in a good way, and we can make a complete achievement of the occlusion of the aneurysm. And this is how important the positioning and the shaping of the microcatheter with a looping microcatheter like this. This is the para-ophthalmic aneurysm located here, and this is the shape. And we can push the microcatheter, and then we can retract and put the microcatheter inside the aneurysm in a stable position and a good angle, so we can easily occlude the aneurysm by coils. This is the PCOM aneurysm in small neck. So with a single microcatheter with a 90 degrees of pre-shaped microcatheter, we can occlude the aneurysm. And so, and then without the second microcatheter, the aneurysm can be occluded perfectly. This is the right ICA aneurysm with the SAH and his grade 3, and you can see that this is the right ICA aneurysm. So with a single on the microcatheter and with the long-standing position of the intermediate catheter, we can occlude the aneurysm with the coils. So how about the aneurysm with the inappropriate dome to neck ratio? We can use some technique like a multiple microcatheter technique. We can imaginary compartmentalization the aneurysm for the multiple or double microcatheter, one microcatheter for the coil anchor and the other for filling, and then make the coils intermingle each other. And then after good positioning, we can detach the anchor coil as the final detection. It's like the inflow and outflow zone in the superficial and deep zone and the multiple aneurysm. So we have to use the larger guiding catheter, like a 6 French or 7 French guiding catheter, and the second microcatheter as a salvageable microcatheter. So this is another rupture aneurysm cases. This is an ACUP aneurysm cases. So so we decide to put the coils, and then after put first microcatheter, and then we realize that this is not a good position. And then we proceed to insert the second microcatheter, and then we can see that from by the combining the first and the second microcatheter, we can make a good occlusion of the aneurysm. So how about the mechanism of the aneurysm healing through the EVT? You can see that neck coverage of the aneurysm is very important. So we have to make a good packing coil density. And then flow diversion with the help of the stent or even the flow diverter, it will make a neo-intimal formation. So also with the use of some proper device like stent, the remodeling of the vessel branch can be helped for the complete treatment of aneurysm occlusion. Like we mentioned before, that the previous presentation, that some techniques to put the coils inside is very important to reduce the risk of the thromboembolic complication. This is some step devices like a stent or balloon, and then like a multiple microcatheter that we discussed before previously. For the balloon remodeling or balloon asset coiling, the balloon placed in the parent vessel and then inflated during the deposition of each coil. It is deflated between each coil and then removed at the end of the procedure. Mostly, we use the balloon for the wide neck aneurysm in the acute rupture aneurysm. It's like this case that this is the 83-year-old male with the SAH and hydrocephalus. We can see that this is the location of the aneurysm in the paraclinoid in the left ICA. This is the aneurysm. It's quite a wide neck. So we put we use the double micro and the first micro for the balloon, and then you can see that we place the balloon around here, and then we put the coils to occlude this ruptured aneurysm to make a good backing density. This is another case. This is quite a debatable case. This is the very old female with a cardiac problem with the SAH in the MCA. So we decide to put the coils, and then because of we can see that this is a quite doomed to neck inappropriate ratio, we use the balloon remodeling and we use the stent. We use the coils, and then you can see that we can make a good coil compaction with the balloon assisted technique. How about the stent assisted coiling? With the stent assisted coiling, so we can have advantages and disadvantages. With the stent, we can make a good result of coiling, as we mentioned before, and then we can also make a good we can prevent the neck remnant, and then so we can make a good occlusion and also the long-term outcome. But the disadvantages that this is the complex procedures, and also it is a dual antiplatelet. So in my center, we are not we never use the stent for the ruptured case, and then this is also problem about the issue of MR imaging artifact for the follow-up of the patient. So we use stent-assisted devices only for the unruptured case, and then we prep the patients with the antiplatelet combination for some period. So this is the paraclinoid. This is superior hypophyseal artery aneurysm, and then we decide to put the coils because we see that this is quite the aneurysm has a doomed to neck ratio that more than 2, and then we decide to use the stent assisted, the coils, and then this is the sorry, okay, and then this is the stent. We can see the picture of the stent. This is the stent, and this is coil, and we put the coil with the stent in the parent vessels. Okay, this is the final result. So we have to know the characteristic of the stent. That is whether it's a laser cut or graded, this is open or closed cell. How about the wall opposition, flexibility, and conformability? And then we can see that from the technique we can use the J-link on transcell. This is the stent that available in market in Indonesia. We have a Nuform, Leo, Elvis, or the solitaire stent. And then by knowing the characteristic of the stent, we can avoid this kind of stent malfunction like this one. This is the stent in the angle is quite a kink position. So we have to use the proper type of stent for avoid this kind of complication. This is another case, this mid-basilar aneurysm. So we use the stent assisted coil for this kind with the J-link technique, and then we use the stent inside the pen vessel and then complete the occlusion of the aneurysm in the mid-basilar. So this is the algorithm in my department for the ruptured cases, because we know that in Indonesia and also especially in the hospital, in my hospital, that most of the cases come with the ruptured case. So this is the algorithm that for the ruptured case that we divide the aneurysm based on the location, and if in the anterior location with a mesh effect because of the ICH, so we proceed the patient to the surgery. And especially for the MCA aneurysm, and then for without the mesh effect, first choice is the surgery with good height and haze, and then for the bad condition for the patient, we proceed to the EVT. For the posterior circulation, most of the cases went to goes to the endovascular, to EVT, and then if there's a special consideration, we can change between procedures. So this is the latest stent that we have, that for the large giant ICA aneurysm, we can use the flow diverter. This is the comparison picture of the flow diverter and the regular stent. You can see that this is the flow diverter. It has more dense porous, and then this is the regular stent that is more sparse porous. So for the like this one giant aneurysm, we can occlude the aneurysm with a flow diverter instead. This is the case with the ophthalmoplegia, and then this is the aneurysm, and then we can put the flow diverter to this kind of aneurysm. You can see this is the immediate result. Still the branch vessel is persistent. So the conclusion is that the development of devices and endovascular treatment technique in the aneurysm is very fast, and this is quite challenging for us. And the large amount of stroke cases due to the aneurysm rupture in Indonesia is still a burden, especially for the cost and for the morbidity. And then case finding of unrupture, like Professor Hiroji mentioned in the presentation, should be encouraged to reduce the burden of the aneurysm rupture cases in Indonesia. Okay, thank you very much.
Okay, thank you, Dr. Iwan. So all the three speakers already present their presentation, and now we move to discussion and question and answer session. So we have now three panelists, Dr. Adam, Dr. Adiguno, and also Dr. Wayan. Do you have any specific comment or question to these three speakers, please? Dr. Adiguno, maybe.
Okay, thank you, Dr. Asra, and a very wonderful presentation by all the presenter, especially Dr. Prof. Hiroji. You remain us again about the basic and also the advanced technique of the clipping, and for Dr. Iwan and also Dr. Abrar, you challenge us, all of us, to treat the aneurysm using the endo or the clipping technique. Okay, Prof. Hiroji, maybe one question from me. Based on the presentation or the video you show us, we see that you treat on the MCA rupture and unruptured case. So first, what is your consideration to treat the unruptured case of MCA? Is it did you find it accidentally, or there's the symptom or clinical symptom from the patient, so you treat the unruptured case of MCA, or another consideration? And the second question from me, for Professor Hiroji, from your video, I never seen the temporary clip for the MCA. So what is your consideration to when to use the temporary clip in your operation for the MCA aneurysm? Maybe that's first from the Prof. Hiroji. Thank you, Dr. Asra.
Okay, Thank you, Professor Horichi. Two questions, please.
Thank you very much for important question. Unfortunately, I cannot understand the first question.
Indication for treatment for unruptured MC aneurysm. Because
Okay.
no symptoms, please. Yeah, indication.
Based on Japanese treatment guideline, over 5 millimeter aneurysm should be treated. So I think the size is very important. However, some patients have anxiety for subarachnoid hemorrhage due to family history. So I think the aneurysm is small. However, some bleb is available. I should treat small aneurysm after discussing the risk and benefit of clipping surgery with the patient. Is it sufficient, or I'm not sure? It's okay.
Yes, we can understand. So.
And the second question, temporary clipping for MCA aneurysm. I think temporary clipping at M1 is very dangerous to occlude ventricular straight artery. So I don't like temporary clipping at M1 portion. If the aneurysm very fragile, natural, and temporary clipping is needed, I place ICA and A1 not to injure ventricular straight artery. If the MC aneurysm is ruptured, many cases it can be controllable because the aneurysm location is not so narrow and not so deep. However, ICA aneurysm, it is difficult to control the premature rupture. So the aneurysm is located ICA. I don't hesitate to place the temporary clipping at proximal ICA.
Yes. Okay, thank you.
Thank you, Prof.
Yes. Dr. Wayan, maybe you have a question or comment. Please, Dr. Niriana. Please unmute yourself.
Okay, thank you, Dr. Asra. Okay, thank you, Dr. Asra. Thank you, Professor Hiroshi, Dr. Abrar, and Dr. Iwan for the nice presentation and lecture about the clipping and endovascular therapy. So I have a question for Professor Hiroshi and others. The first for Professor Hiroshi. What is your tip and tricks to prevent intraoperative rupture or premature rupture for your surgery or for your clipping? And for Dr. Abrar, for the rupture aneurysm that you did endovascular treatment, so when is the best time to do DSA or direct to do FPT? And in BPJS area in this time, so how you choose the optimal clip for, of course, we need the minimal cost for the clipping. And the third for Dr. Iwan, if you have a case of SEH with hydrocephalus, so what did you do first? EVD first or VP shunt first or just direct AVT? Thank you very much.
Okay, thank you. 3 questions for each.
Each other, yeah.
So first, to Professor Horichi, how do you start to prevent early or premature rupture? Okay, please.
The minor premature rupture can be controlled, a simple compression and suction. However, the major premature rupture should be controlled using temporary clip. So some premature rupture, I think, can be controlled. Fibrin glue and surgical compression. It's very useful to temporary hemostasis when the minor rupture occurred. It's okay.
Okay, thank you. So there is some strategy to prevent Professor rupture, and after rupture, you have strategy to that Professor Huruji said to put some surgical and fibrin glue maybe. Yeah. And second question to Dr. Abrar.
Thank you. The questions from Dr. Wayan is how we choose from CT angio. Usually the first modality is a CT angio. From CT angio, how we choose the patient is candidate for clipping or candidate for coiling. And when we perform the SA to emphasize the choice. So usually we really maximize the CT angio. So with good CT angio, so I think more than 90% we can directly decide whether the patients go to clipping arm or the coiling arm. But in some cases, like if we cannot see, like ICPC aneurysm, we cannot see whether this is a anterior cradle aneurysm or PCOM aneurysm, with whether this is a PCOM is a fetal PCOM or non-fetal PCOM, whether we can sacrifice or not. So we decide to perform the SA first. But sometimes, because the CT angio cannot really 100% differentiate whether the patient can go to clipping or coiling. So sometimes from the angio room, so we already prepare patient for coilings. So we see, oh, this is a wide neck, which is dangerous for coiling. So we move the patients, go to the OR, go for clipping. So usually every time we perform the coiling procedures, I always prepare an OR standby for switch the patients go to the OR if something happens in the angio room. For the second questions, I'm sorry, I forgot the second question.
But the BPJS era, how you manage strategy? Yeah, BPJS financial.
Oh yeah. How the number of clipping? How to reduce the number of clipping? So honestly, clipping surgery is still make me palpitating. So I never counted number of the clip blade, the clip, the number of clip that I use. So usually I try the simplest clip, straight simplest clip. But if it dangerous, make a compromise to the flow of the vessels, so never mind use several clips, stacking clips, several clips. So that's we should discuss to the hospital, because a clip already, we go to the clip because it's cheapest. So one clip in Indonesia in my hospital, one clip is maybe cost with the tax, hospital tax and others. So I think one clip will cost around 300 to 350 US, I think. So it's, we use 2 or 3 clips, is still cheap compared to one coil. So I think we should discuss to the hospital so they can understand that we cannot really reduce the number of the clip. We tried it, but never compromise the result with the strategy. So I think.
Okay, thank you, Dr. Abrar. So, Dr. Iwan, you have any comment about the question from Dr. Wayan? Please.
Thank you, Dr. Nia. Actually, it's based on the on the hospital itself. In some hospital, the angio room available for 24 hours, but in some hospital, it only available in the working hours. So in the SH cases, with the SH with the hydrocephalus, so we have to occlude the aneurysm first before diversing the LCS. So and then LCS diversion we can use whether with the EVD or the lumbar drain. So basically we see the CT scan if hydrocephalus with the minimal intraventricular hemorrhage or even with a no IVH, and then we decide to do with the temporary lumbar drain. So we put coils first, occlude the aneurysm, and then in the angio room we insert the lumbar drain, or if it's in the intraventricular hemorrhage, and then we put also EVD directly in the angio room. But it is we do after the coiling. After the coiling, is it if the angio room is 24 hours? Is it possible? But if different situation, maybe we have to do the diversion first, and then see the patient condition, and then do the surgery or the EVP. Thank you.
Okay. Thank you. I think it's very clear and complete explanation, Dr. Wayan. Okay. I think it's one question from the Q&A panel from Dr. Yunus. This question is for Professor Horiuchi. He asked about how is the strategy to dissect the dome of the aneurysm that safe that not trigger the intraoperative rupture. So how is your strategy to dissect the dome of the aneurysm to prevent rupture, early rupture? Yeah, please, Dr. Prof. Horiuchi. Please unmute yourself, Professor Horiuchi. Yeah.
I'm sorry. Yes. Thank you for the question. Of course, the aneurysmal wall is very thin. In this situation, the dome clipping will induce the premature rupture, of course. So dome clipping is safe for thick wall of the aneurysm. And if this aneurysm is ruptured, tentative clipping is better, except for dome clipping. Is it okay?
Okay. So do you have some specific instrument to dissect the dome aneurysm? What is your preferred?
I think silver dissector is one of useful tool to dissect the aneurysm. Some famous neurosurgeon in Japan like scissors comparing with dissector. However, it is difficult to use fine movement of scissors for especially young neurosurgeon.
Yes.
So I recommend the young neurosurgeon to use silver dissector around the aneurysm from surrounding structures.
Okay, thank you. So there is another. Please.
Boleh.
Okay, Dr. Abrar, please. You have some comment.
Professor Horiuchi.
Yes.
Thank you. Professor, I have a question about vein preservation in sylvian fissure splitting. So sometimes I got difficulties to preserve the vein. So and I should sacrifice the vein to expose the dome clearer. So do you have a strategy to decide we can sacrifice this vein, we cannot sacrifice this vein?
Thank you for your question. Recently, venous evaluation technique in acta neurochirurgica. We recommend the temporal clip to use this vein, whether this vein can be sacrificed or not. This method, if you have to sacrifice this vein, however, there is no collateral pathway or not. In this situation, this vein was temporarily occluded using low pressure temporary clip, some anastomotic clip, and then ICG is showing the collateral pathway is available or not. If stagnation of venous flow, this vein should not be sacrificed. However, you can see collateral pathway, you can sacrifice this vein. Please read the article written by Dr. Ritsky.
Okay.
Okay, thank you. Thank you. Wow.
Dr. Rizky is a PhD doctor program in Sinci University from Semarang. Yes, yeah, I know him well too. So maybe in these 2 years, maybe he finished.
He's attending this meeting, I think.
Oh, Rizky, ya, wah, ya, semoga bisa ketemu ini nanti. And then I think the other panelist is Dr. Adam. Yeah, please, Dr. Adam, please show up your face to the audience. Dr. Adam is from Bandung. Dr. Adam, you have question or comment? Please, Dr. Adam.
Maybe I can ask Dr. Asra another panelist for another presenter.
Yeah, okay, he's not here. You have question, Dr. Adiguno?
Yes, I have a question for Dr. Abrar and also Dr. Nurstiawan. Okay, for Dr. Abrar, it's interesting in your last summary that you said that difficult anatomy, thrombus, and giant, you choose clipping. So it's maybe for you that you have already have much more, and Dr. Alsa also maybe, and Prof. Hirochi, that you have much more clipping history, make a clip treatment with clipping. So maybe you will have a confidence more than another young neurosurgeon. So why do you choose the clipping for the difficult anatomy, thrombus, and giant? So can you have a consideration for us? And how to develop the confidence? How to develop the confidence for the young neurosurgeon?
Yeah.
For Dr. Abrar. And for Dr. Iwan, said that if there is the remnant aneurysm sac, so what is your consideration to make another treatment for the remnant aneurysm sac after you perform the endovascular treatment? So can you tell us what is your consideration?
Okay, Dr. Abrar, how do you choose between two of procedure?
Maybe this the question is how we choose the treatment arm, whether clipping or coiling in complex aneurysm. Why I choose more for clipping surgery. For the complex aneurysms, it's a complex. Usually, it's very complex to coiling because for complex aneurysm, usually for endovascular treatment, we need usually supporting treatment, not a simple coiling. Sometimes we need a coil, sometimes we need balloon, and some of the devices are still difficult to get in my hospital. So usually, the most technique that we use in the most device that we have in our hospital just for simple coiling or simple stenting coiling. So, and most of the patients come with rupture cases, then I still believe that put a stent in rupture cases, it's still not good because After rupture, we need to put a lumbar drain. We need to put a shunt, maybe we need to put an EVD or so on. So with a stent inside the vessels, we should put an anti-platelet, and we will limit our strategy next. So that's why for the complex shape of aneurysms, especially for MCA or ACOM, I prefer to do the clipping because I can see and we can reconstruct the parent artery is better.
Okay,
I think so.
Thank you, Dr. Adam. And I think Dr. Iwan has some more experience using a stent and how about this, and also the remnant aneurysm after surgery or treatment. Please, Dr. Iwan, you have some comment.
Thank you, Dr. Adikuno. It's very nice questions. Actually, that we can predict that in the future, in the few years, we will be facing the problem about the aneurysm regrowth due to loose coil packing. So, in my opinion, if the aneurysm growth and then there will be there's some mass effect due to the aneurysm growth with the coil inside, so we have to move to surgery if it's possible to decompress the mass effect and then to secure the aneurysm, because sometimes the aneurysms in the rupture case, some EVT surgeon, they put the coils only for the salvaging coils. It means that they put coils only to prevent the re-rupture. And also we have the situation in Indonesia that the coil option, the coil numbers is not as complete as in the foreign abroad, right? So mostly in the rupture case in our country, in Indonesia, sometimes it's a salvageable coils. So we can predict in the future the aneurysm will regrow. So it will be there will be some problem. So in my opinion, if there's some mass effect due to the regrowth aneurysm and the coil inside due to the decompression with the surgery, but if the aneurysm sac is a small and there's the mass effect, we can just put some coils and then cover it with stent or finish it with the last effort of EVT, which means flow diverter. Because if we put the flow diverter and then it's very difficult to proceed to another EVT procedure or surgery, right?
Okay.
So we have to put the patient with the antiplatelet. That's my opinion. So still consider the surgery for the regrowth and mass effect with the coil inside of the aneurysm.
Okay, thank you, Dr. Iwan. And on Q&A panel, also one question more from the participant to Professor Horiuchi. He asking about the strategy to compression aneurysm dome using the suction decompression or direct puncture. Do you have explanation? Yeah, how to strategy to use the suction decompression or direct puncture of the dome aneurysm? Do you have some experience? Please. Yeah.
Thank you very much. It's depending on aneurysm location. For paracrinoid or ICP-COM large aneurysm should be treated using suction decompression technique via cervical internal carotid artery. And for the MCA aneurysm, direct puncture is very simple and useful after trapping aneurysm. I think the aneurysm induces mass effect and some symptom. The aneurysm should be punctured and decompression is needed.
Okay. Because the time is very limited, so I will ask one question to Professor Horiuchi. I know that since you have two modalities therapy of clipping and open surgery, and also Dr. Koyama, I think I know he's doing more in endovascular. So how you manage the aneurysm decided by these two kind of treatment in your institute? Please explain to us.
Yes. In Japan, endovascular procedure will getting popular, and many patients hope to undergo the endovascular surgery. So some patients are referred to endovascular surgery, no clipping surgery. However, I think the aneurysm has some mass effect causing visual symptom, such as it should be treated clipping surgery. And I think the stent placement is a troublesome. So the aneurysm is very complex. The stent is needed for MCA aneurysm. I think the MCA aneurysm should be treated by clipping, although the patient hope to receive endovascular treatment.
Okay, thank you. I think because of the time, I think we should finish this webinar. So thank you very much, Professor Horichi, for
Thank you very
your
much.
time. And please send my regard to Rizky here. And also all the participant, all the speaker and panelists. Thank you very much. I hope we can see again in another valuable webinar again. Thank you.
I hope so.
Professor, okay. Sayonara.
Sayonara. See you soon in
Thank you,
Asia
thank you.
or Japan.
Thank you, Profesor.
Terima kasih Pak Iwan, Pak Asra.
Ya, terima kasih ya.
Ayan,
ya, Adik
Ya,
Seno.
terima kasih semuanya.
Ya, masih. Terus Adam tidak bisa ini hadir ini. Ya.
Makan dulu, Pak.